Greetings all. Welcome to the fourth of the Implementation Learning Seminar Series organized by Nest 360 and UNICEF for the Newborn Toolkit Joint Learning Community. My name is Nina Karka and I'm the Newborn Health Focal Point for the USAID Momentum and Country Global Leadership Program. I am very pleased to represent the Family Centered Care Working Group today and promise you a very exciting session of lots of learning today because we have a really packed session today. So I'm starting away right away. I think many of you might have attended the earlier three series and are already aware of the aim of the series. The webinars is to encourage collaborative learning for the advancement of small and sick newborn care. Today, we are offering you a webinar, which we hope will be a unique learning opportunity for all of us. We will together learn about family-centered care and how it helps babies and families overcome the stress, the bewilderment, and intense sadness that sometimes parents face when they are suddenly faced with the situation where their much-awaited happy occasion quickly turns into a world of chaos. To learn together, we have for you two sets of parents with babies who graduated safely to their full potential under the nurturing, innovative, family centered care provided by Professor Arti Maria and her extremely hardworking, multidisciplinary team of health workers in the NICU at Ram Manohar Lal Lohia Hospital in New Delhi. This will be followed by presentations from an expert panel of practitioners and academicians. So, without much ado, let me just start off by introducing you to the parents, Kiran and Daniel, parents of very beautiful and smart daughter, and to Anjali and Karunesh, parents of very intelligent and handsome 14 years old son. I believe Karunesh has dropped off and is rejoining, but we can start off. Uh, has he joined, Mita? Okay, rejoining. In the meantime, I will be saying that as the session goes forward, please think of all the questions you'd like to ask the panelists. We have an expert group, including the parents themselves, who are much more experienced than many of us. So chat your questions in the chat box and we will ensure that you get your answers during the sessions or towards the end of it, or even via emails. Is Karunish back? Karunish and Anjali? Okay, fantastic. Okay, thank you, Karunesh, Anjali, and Daniel and Kiran for joining us today. We are so grateful you have joined us today to share your experience, and we want to learn from your experience. I think we can spend the whole day learning from all four of you, but today we just have around 10 minutes to hear your stories, so let us begin immediately. Daniel and Karunesh, fathers of the two kids, can I request you to go back in time and think of when you saw your little baby in the NICU bed in RML for the first time? Can you very, very briefly describe the scene for us, please? Karunesh, can you unmute, please?
Frankly speaking,
I think Karunesh's network is giving problem. Maybe Daniel, are you on?
Hi everyone, can you hear me?
Yes, we can. Go ahead. Why don't you speak while we get Karunesh back on?
Sure. I would like to first begin with thanking the panelists giving us the opportunity to share our experience here. And uh, our first thoughts on seeing a baby in the NICU at Ram Manohar Lohia Hospital in Delhi under the able and expert care of Dr. Aarti Maria, was a bit, we were a bit terrified. And we were, if you ask us, we had a preterm baby who was born of 1.1 kgs and was about 7 months old. And so we were in for a shock. Nobody expects a child to be born preterm. And then even after a child is born, many of them are quite healthy, but ours was not. And so she had to be admitted to the NICU. And we were quite terrified at that moment. We were in trauma. My wife, who had given birth to our daughter, after having gone through the pregnancy and the delivery, physically, mentally, emotionally, we were quite shaken. So those were the initial thoughts and our picture at that time.
Can imagine. Yes. I can't imagine how terrifying that must have been. Is Karunesh back? No, I don't see him there. So why don't we just continue? Uh, Kiran and Daniel, when you were told by by Dr. Arti Maria and her team that you are going to be invited to take care of your little baby hand in hand with them in the NICU, what was your reaction, thoughts at that point?
The family-centered care program that Dr. Artimaria has at her hospital was, and I think it's still a new concept, and it's not very widely practiced. And so for us, we were quite new to the program, and what we had heard of the other places was the baby is admitted in the ICU, and the parents can just go and visit the baby once in a while. So this was quite new to us, and we were a bit skeptical how how this would go through and how we would manage it. So we there were a lot of questions in our mind, and but as we went through the whole process, we got acquainted with it, and we gradually realized, the benefits of the family-centered care program.
Fantastic. Karunesh, I believe you and Anjali are back. I'll repeat the question for you.
Yeah.
You can hear me? Okay.
Yeah.
Okay, great. Karunesh and Anjali, can I request you to go back in time and think of when you saw your little baby in the NICU bed in RML for the first time? Can you very briefly describe the scene for us, please?
Ma'am, first of all, a baby can be born at 6 months and 6 days. We had never heard of it. So it was something very extraordinary for us. We were very worried and we were very frightened for that. And everybody we met was told us that these babies have very remote chances of getting healthy and getting surviving. So the experience was not very good for us at that time, but we were hopeful to do the best for them, and we are so thankful to the complete RML team, Dr. Maria and Dr. Behel and Dr. VK Gupta. They helped us in just coming over all these experiences.
Thank you, Karunesh. Is there one word that comes to your mind of what you felt when you first saw the baby? Anjali.
I just felt hand to heart to my mouth.
Can you come a little bit closer to the mic, please? Anjali, I couldn't hear you.
I just felt heart to mouth. I can say this only.
Very traumatic
Very
scene.
traumatic scene. I just felt my babies are going from my hand, from us. Very. It is very painful to remember.
Even think about it. Yes, yeah. I can imagine. Thank you. I just wanted to share what you had felt because it's the real thing, and many of us don't even realize it. So my question to you, Anjali and Karunesh, if you were to think of 3 points that made it easy for you to take care of your baby when he was still in the NICU, what are those 3 points? What helped you to take care of the baby? Because as Daniel was saying earlier, this was very new concept.
Yes. First of all, our willingness to serve our babies, because everybody was telling us that these babies have very remote chances to survive. So we thought as much we can serve them, as much we can help them. Second thing was, we were being told that these babies take long time to survive. So we knew that we will not be always have the expertise of medical professionals at our disposal. So we wanted to learn from RML team, because we had those experts there. So as much as possible, so that when we come out of that hospital and the baby is at our home, so we can take care of the baby independently. And the third thing was, it is very difficult to arrange a medical expert every time at home. So we wanted to ensure that whatever we can learn, whatever maximum we can learn, we should do it, and we should work at our own with our own hands, so that after the baby is discharged and we are back at home, so we can take care of the babies independently.
means we must have that much of confidence that we can take proper care of that delicate and the babies, that much delicate babies and serious babies.
Were you frightened to hold the baby when the baby
Yeah.
was in the NICU?
In the very beginning, we were very much frightened, but with the help of all the doctors and nurses and all the staff, we were very much confident to take our baby in our arms, to arrange him for the X-rays, for ABGs, for BBGs, to all the tests which were going on during that period.
We would hold the wrist of a baby when he was being pricked for ABG and BBG,
So,
sometimes even 40 times.
Yeah.
A
So,
day.
Anjali, how long was the baby in the unit? How many months?
3 months.
Thank you.
On
And Daniel and Daniel and Kira, how long was your daughter in the NICU at that time?
She was there for 7 months.
Goodness. So let me ask you, you just briefly described the condition of your baby when she was discharged at 7 months. What was the condition like as she was being discharged? And how did you take care of the baby at home after 7 months being in the NICU, both of you there side by side with the baby? What happened? Tell us what happened to the baby. How is the baby?
Yeah, to be precise, I just wanted to make a small correction. In total, she was in the NICU for 8 months, 257 days, day in and out, day and night. And she was on the ventilator in between for 57 days. And we had lost all hope that the baby would survive. And even after, so as she came out of the ventilator, Dr. Maria suggested, advised us that we now better take her home. And this was towards the end of the whole hospitalization period. But our baby was still on oxygen support. And we were quite disappointed that after about waiting for 8 months, we still had to take her home on oxygen, because we had waited all this while so that the baby would heal up and we would take home a healthy baby. But unfortunately, that didn't happen. But with faith in our doctor, faith in our God, Lord Jesus, we took that step of faith, that leap of faith, took her home on oxygen. Now, what helped us while taking the baby back home was our experience of these last 8 months in the 7 months in the NICU. So 1 month we had stayed at another hospital, 7 months under Dr. Ati Maria's hospital in Ramanaloya. And so those 7 months of learnings in the ICU gave us the confidence that we could take care of our baby at home. We were very confident of the different procedures of how to handle the baby, of how to prepare our home, just like an ICU, maintain the hygiene conditions. We learned about the medicines, we learned about the dosages, the calculations, and we learned about the emergency first aid steps to be taken. So the family-centered care gave us the confidence to handle our baby at home. And we gave her oxygen at home for 2 more months after those 8 months of hospitalization. And after those 2 months, by God's grace, she weaned out of oxygen.
Fantastic. Oh my goodness, what a successful story. And Karunesh and Anjali, was your story similar when you were discharged? What was the routine you followed when you went back home? And if you could say it in just 1 minute, please. We just have 2 minutes to wrap up.
Okay.
Karunesh?
The first thing that we did was we told all our relatives and friends not to visit our home till our baby is 1 year old, because he was prone to infections. Second thing, we followed extreme hygiene conditions. The baby was not taken out of bedroom, 24 hours in bedroom, and the floor was being mopped 4 times with the antiseptic chemicals and everything. This means formalin and everything. And when I would come back from office, I would go to another room, wash myself, change clothes, use sterilium, the disinfectant at that moment of time, sanitizer, and then I would touch my baby. So Anjali would take care of the baby. She was 24 hours with the baby only, and she was more of a doctor and nurse to take care of the baby in every possible.
My son was on feeding tube, so I gave feed with feeding tube, and because of the help of the doctors, they guided us from in our RML. Our son was on and off on ventilator for 3 months. He had brain hemorrhage, gastro hemorrhage, PPHN, respiratory pneumonia, and many more problems he had during
My
that
goodness.
period.
Thank you. So if I would just a wrap up question for each one of you, if you were to speak to our our audience are physicians, nurses, programmers, one sentence, if you were to advise from your experience, let me ask Coronation Anjali first, very briefly, just one sentence. What would your advice be from your experience?
Please educate the parents as much as possible so that they are independently taking care of these preterm babies, and also this will help you to concentrate more on the technical side rather than on looking non-technical side and normal things like pressure of oxygen in ventilator, flow of oxygen in ventilator, how is the baby performing, SpO2 and everything. We knew everything.
Output, stool output,
Everything we knew.
Thank you.
BPM and
Goodness.
the
everything.
color of the baby. If
Color
it
of
is
the-
pink,
Yeah.
he is okay.
Yeah.
He is
Thank you.
active, he is okay.
That is what
Thank you.
Dr.
Let me
Maria
give to
told us.
Daniel and Kiran. Thank you, Coronation Anjali.
you.
Daniel and Kiran, any one sentence? I know we are under pressure with time.
Yeah. Parents should be made a part of the treatment and the healing process. That really helps a lot. It helps both ways. The parents get confidence and the child also benefits greatly from such a care. Thank you.
Thank you so much. This is fantastic. I think we could have spent a whole 1 hour talking with you all, more than that actually, to learn actually from your experience. But what you shared today was extremely good. I'm really grateful. And on behalf of every one of us, thank you for it. We are very honored to be part of this small story, your journey in life, and all our blessings that your children grow to have a long, happy, and successful life. Thank you.
We are grateful to Dr. Maria and all the team. They helped us and they motivated us and they educated us, advised us, guided us in such a beautiful way that our son is now 14-year-old and he is still doing very well.
We want to create many more Aarti Marias in the world now. We are so grateful that she's there with us today. Thank you so much.
We hope and pray there are so many of them.
Thank you so much.
Thank
so with this, thank you. I wish I could continue, but I'm now going to turn the presentations to our expert panelists. Our expert speakers will introduce themselves and hand over to each other to save time. So let me just quickly pass the mic to Jaya. Jaya, please introduce yourself and jump straight into your presentation and hand over to Maureen right after. Over to you, Jaya.
Thanks so much, Nina, and what a powerful start to the seminar. So I'm Jaya Chandler. I'm a child psychologist working at the London School of Hygiene and Tropical Medicine and a part of this family-centred care health system building block team. So I'm going to quickly give you an overview of the toolkit, how we got here, and invite you all to join us as well. So for those of you who are not familiar with the implementation toolkit, Meeta's going to put a link in the chat so you can check it out yourselves, and I'll talk a little bit about the team behind the family-centred care building block. So this team is led by Tedbab and Maureen. Maureen you'll hear from in just a second, and Tedbab sadly couldn't be here today as she's busy attending another meeting. Then there's Nina, Silky, Suman, Aarti and myself in the smaller core team, but we are supported by people all over the world who've come together to share their resources and knowledge on family-centred care, which led us to building this health HSBB. So what is the toolkit? It's an open access resource hub and it's a one-stop shop for materials. So when you access the website, you'll see these pages come up and you can click through the family-centred care building block and find out about more about all of these different areas. It's an open access website and it collates practical resources, tools, and active learning for small and sick newborn care. And it addresses all sorts of different areas within the health system. So practical things like floor plans, data tools, device maintenance checklists. It's a resource, very wealthy resource. So for family-centered care, the core theme behind family-centered care revolves around the mutual relationship between the family and the healthcare providers. And we just heard how important that is from those parents who just gave their time today. We know that every family, when they have a newborn, they dream that their baby will survive and thrive. And if their newborn is sick, it can be a time of great anxiety and emotional distress. Families can feel excluded from their care, and this can be because of distance or lack of communication with staff or fear of the technology. And we aim to put together a resource that would help build strong family-centered care, both in the hospitals and post-discharge. This is the basic structure, and I'm going to give a very quick overview, but there's plenty more detail in the website, and you'll hear a bit more in detail about certain parts of this structure in the following talks. So first, we have organisation of care, which includes developmentally supportive care, effective communication and meaningful participation, emotional support and mental health for parents, and bereavement support. We've included a section on kangaroo mother care, which gives guidance on zero separation, breastfeeding, developmentally supportive care, education and training. We've also got a section on discharge and early child development. This is about using existing community structures, such as village health committees and community health workers, to link between the community and the health facility. The importance of follow-up home visits, including neurodevelopmental screening of high-risk infants, and peer and parental support groups. And then finally, and maybe most importantly, parent power. The idea that family-centered care goes beyond the relationship between the health worker and the family, and it includes the mutual relationships and supports between families themselves. So access to support groups, peer parental support, and making sure families and their voices are involved in the evaluation of policies and programs. And finally, a call to all of you here today to come and join us. We are constantly updating the toolkit, adding resources. And if you have resources that you're using in your practice, we would love to hear from you. And there's more details on how to join in the chat. I'm now going to pass to Maureen, who's going to talk a bit more about the global gaps in bereavement care and some specific experiences from Malawi.
Thank you, Jaya. All right, Maureen Majamanda, as Jaya has introduced me, from Malawi. I'll be talking about bereavement care, and especially I also focus on the gaps that have been identified from the Malawi setting, which may be similar to other similar settings as well. So what I'm saying is children bring so much joy, meaning and sense of purpose to the parents and even to the family. Even the news that the family is expecting a baby, you know, they change their lifestyle and they try to focus on the gift that is yet to come. And when you talk of family-centered care, as already introduced, you're looking at involving the families in the whole stage of life with their child. And also, we're looking at involving the family, including them, for the care of a well child, and when the child is sick, and even when the child is dying. And focus in family-centered care is on the strengths that the family has and also their needs in any given situation, because we understand that families are different. They've got different strengths, and they also have got different needs that have to be identified and made at every opportunity. And bereavement care is just an important part of family-centered care. Next slide, please. And what we're saying under bereavement care is that not all sick neonates survive an illness. And it's a true fact that some of the neonates die. And bereavement care, we are focusing on the family's grief process. We want to make sure that family is well supported before, the death, during the death, and even after a fetal or neonatal loss. So we are talking of even fetus when the pregnancy is lost. The parents, the family who are expecting a newborn or a new member in the family, they go through that loss and they have to be supported at each and every stage. Next slide, please. So in bereavement care, we're looking at reducing the negative effects of bereavement on the physical, social, and even mental health of the family members. We know there are so many problems that may come in due to the loss of the neonate or the fetus, and physically, the family may be distancing themselves from others, or they may also be having some health conditions developing from that if they're not well managed. Socially, you talk about issue of stigma, could be self-stigma from the family, even also the society that they are in, and also that can lead to some mental health problems, which may include even depression. Next slide, please. So if you talk about the Malawi experience, what I'm saying is when a neonate is sick, so we have to keep communicating, and we keep the information on the condition of the neonate is always provided to the family. Whatever is happening to them, if there are lab procedures being done, the results. So there is that continuous flow of information between the family and also the healthcare workers. And also families and even relatives are included and are also allowed to be visiting the family in the hospital and even offer the support that they can provide. And you're looking at the fact that the neonate is sick, is in the hospital, and because they're in the hospital, the family's psychological well-being is also affected. So these are some of the positive things that are done in the Malawian setting to ensure that during the process that the neonate is sick, they are well taken care of. And also spiritually, within the hospital setting, we've got hospital chaplains who provide spiritual care to the families. And also it's allowed that some church leaders or even church members come and also provide some support to the families when they're in the hospital. And also family is continuously counseled on the condition of the baby, the progress, whether the progress is good or the progress is poor, but this information is always relayed to the family. And also when the child dies, or the neonate dies, the family is informed about that, and they're allowed to see the body of their baby and be able to spend some moments with them before the body is taken to the morgue. Next slide, please. And we identified some of the gaps. These are not all of them. There may be more, but due to time, we're just focusing on the things that are really very crucial that we have to consider and also improve on. If you look at our curriculum, the pre-service curriculum, we see that students are not well prepared with knowledge and skills on the management of the families, and even when a death occurs. We know that if you look at the curriculum, mostly we're looking at healthcare workers providing care that should lead to good results, good outcome. But we have to know that it's a fact that not all the time that the best care that you still provide may not end up into good outcome. As such, it may lead to a complication. It may also lead to death. So it's important that during the pre-service training, students are well prepared about this fact, and they have to be provided with all the information, the support, and also they should be prepared emotionally themselves on how they can emotionally be true to their emotional needs before they manage other people's emotional needs. And in terms of those that have qualified already, we have noted that there is lack of competence on the part of staff on how the care that they can provide to the family when the neonate dies. And also in our setting, physically, the infrastructure, there are no private rooms specifically for the bereavement care, because we know if neonates are in the same ward, the parents are there, even the other family members are there, everybody has got a child that is live, though they're experiencing problems. But the fact that the child is alive, it gives them hope that something better will happen. And if a neonate dies, being in the same room with others who are able to hold the babies is so frustrating and also emotional. So it's important that these parents and family that have lost their newborns, they're supposed to have a specific room where they can grieve properly. So in this one, we have a gap there where no private rooms for such settings within our public facilities. Next slide, please. And also there are inadequate skills on breaking bad news to family. We all enjoy breaking the good news, and whatever the situation is, bad news is difficult to break. So same with healthcare workers. Most of the times they find themselves in situations where they have to break this bad news, whether it's a complication coming in, another advanced care to be provided, even when death occurs. So few people have been trained on that, but still they find themselves to be inadequate at some point in time when it comes to breaking the bad news. And also with the heavy workload that we have in our setting, healthcare workers do not spend much time with a grieving family. So when a neonate has died, a family has lost a pregnancy, they may be left somewhere, they may be cancelled, but not for a long time, because the healthcare workers have to also go take care of other people that are in the hospital. So as such, the family feels like it's been abandoned when it's not the case. And also because of that, most family is left alone to make funeral arrangements right in the hospital setting. And this also makes the family to feel that they're alone, they haven't been supported properly because of the challenges that are available in the setting. Next slide, please. So what I'm saying in summary is that bereavement care is as important, just like any aspect of family-centered care. And also we have to make sure that we include bereavement care in the pre-service curriculum so that students, while they're being trained, they have to understand that life can turn out to be different. At the time that we're expecting good news, bad things come in, but still there has to be continuity of care even during the bad times. And information has to be relayed properly so that the family takes it, and then they also have to be provided with appropriate care to feel that much as the negative has happened, the staff, the members are there and also feel for them. And also there is need that we have to develop resources to train healthcare workers in bereavement care for the family, because this is urgently needed. If we don't do this, we shall continue experiencing gaps in bereavement care. Thank you so much. May I now hand over this to Hannah.
Thank you very much, Maureen, and thank you for sharing your excellent work and thinking from Malawi. My name is Dr. Hannah Blenko, and I'm an Associate Professor at London School of Hygiene and Tropical Medicine. And I'd like to zoom out a bit now. We've been here about Malawi, but think again to the global picture, thinking about what we can learn from each other across the global community, and what resources are available to help us close some of these gaps that Maureen's highlighted to us. Next slide, please. So thinking now is not just about neonatal deaths, about stillbirths as well. And actually, I'm going to start the story thinking about stillbirths. So in the Lancet End in Preventable Stillbirth series in 2016, there was a number of targets, and it really recognized the large impact of the more than 2 million stillbirths globally each year on individuals, families, caregivers, and health professionals. The series itself included much work around mortality targets and milestones and reducing stigma. But I'm just going to focus now on the call for a global consensus on a package of respectful bereavement care after a death in pregnancy or childbirth for effective family, community, and caregivers in all settings, and thinking about what progress is being made and where are we. Next slide, please. So first steps that were done on a global level was doing two systematic reviews, one amongst low and middle income countries and one amongst high income countries. And they identified 43 evidence-based themes for respectful care after stillbirth in these settings. And consensus was achieved on 8 key principles for bereavement care from these themes, based on 267 participants from 26 countries. And I put the map in just to show you that there's some big gaps, some regions with no participants at all, and the blue means it's 1 to 5 participants, a very low participation for South Asia and Sub-Saharan Africa as well. And most respondents were predominantly researchers and clinicians. So this really identified actually that more work was needed, both to involve the voice of women and families globally, which is so critical to this, to include neonatal deaths as well. Every single participant said, we can't just think about stillbirths, we need to be thinking about stillbirths and neonatal deaths together, both deaths on labour ward, but also deaths within neonatal units, and thinking about how we implement these principles. Next slide, please. So this is actually a relatively new field in many countries as well. So we know that for much of the neonatal care, high income countries are well ahead of us. But actually, in this case, it's only very recently that many high-income countries have developed bereavement care pathways for deaths, either stillbirths or neonatal deaths. And this slide just shows a few from the UK, from Ireland, and from the right-hand side from Australia as well. And Australia have really been a lead in development of bereavement care packages. Next slide, please. And one thing that's come out from this work is just the limited number of tools available to really to guide and answer these questions around how we improve care for women's and families and healthcare providers in these settings. And I want to highlight this one tool, which is the Improve e-learning and workshops developed by the Stillbirth Centre of Research in Excellence in Australia. And these are available online at the link. They're freely available for anyone to use and can be used and adapted to different settings. They were probably developed for Australian use, but actually have been used in Vietnam, Papua New Guinea, and many other settings as well. I want to highlight the first one chapter here, respectful and supportive bereavement care, which identifies three key areas in terms which Maureen has highlighted to us already today in terms of good communication, shared decision-making, recognition of parenthood, effective support, and organizational response. Next slide, please. So across all this work, I think it's been really clear, and we've heard from Maureen already, that each baby is an individual, and families are individuals with different needs as well. We can't possibly meet all these needs without listening to parents, to babies on the units, and to their parents as well. So there's 4 key areas that have been identified through this work around communication and respect, healthcare provider support and training, addressing stigma and grief, acknowledging the depth and variety of normal grief responses so we can offer us appropriate support, and providing clear information using format and language as appropriate to the context, and investigating underlying causes for death as well. And I think these are really important to say, so we won't go through them in detail just now for time issues, but these are principles that can be used in all settings and in all contexts. And next slide. But if we're going to be able to use in context, we need to understand our own context well. I want to highlight a few pieces of key ongoing work that are looking to better understand stillbirth and neonatal death from the perspective of women, families, and healthcare workers in different settings. So work by the LAMRA network in Kenya and Uganda, by the International Stillbirth Alliance around the Parents' Voice Initiative, and there's links here that you can use to explore this further. And then some work being done under Precise Dyad in terms of development of a bereavement care package, co-development. And this work is linking into the global level in terms of updating the RESPECT study to more formally include women's and families globally and include neonatal deaths. And we very much hope that many in this call will be interested in joining together with this. So thank you very much. And now I'd like to hand over now to Mwanavua Boa from Kembury Wellcome Trust, who's going to talk about health worker experience from Kenya. Thank you.
Thank you, Anna. Thank you for sharing your experiences. So my name is Mwanavua Boga. I'm a nurse manager and a trainer on communication skills and emotional competence for health workers. And I want to share my experience in training health workers on how to communicate well with patients and how to manage the many emotional challenges that they face in their work. Next slide. So this is a quote from one of our NBU nurse sharing her experience around supporting a mother who has lost a baby. And she's saying, I simply tell them sorry, and I don't know what else to do to make them feel better. So these are the challenges that our health workers face in their day-to-day work with their families and parents in the newborn unit. And there is a gap that we need to address in terms of preparing our health workers to be able to relate well and manage the many emotional challenges that they face. Next slide. So we all acknowledge that effective communication and emotional care is key to family-centered care. However, our health workers work under very stressful situations. If I can say from my setup here, our newborn units are usually quite very full, where we have a ratio of one nurse to 50 babies, one nurse to 40 babies. So it's quite very heavy workload. So these emotional situations can influence providers' communication with patients and the ability to provide family-centered care. And we all acknowledge that emotional competence is not taught in our medical and nursing school. And Maureen has alluded that in our presentation. So there's a profound need to bridge that gap between the medical and the emotional aspects of care. The next slide. So the iCare Highland model is a training model that have been running for over 10 years now in Kenya with health workers across different settings. So this is a process training over 6 to 9 months, mainly using reflective learning and experience-based learning approach over time. So the training is divided into 4 phases. So we have a phase 1 where the health workers go through self-observation and reflection on their own communication habits with patients. So we guide them using simple reflective tasks like, how well do you listen to your patients? For a week, just listen, just look at your listening behavior with your patients, how you ask them questions, and the effect of how you communicate to them on the care that you give them. So we have a set of different reflective assignments that we give them during this period of self-observation and reflection to build that self-awareness of how they are relating with patients. And then after that phase, we invite them for a skills workshop. And the workshop, we link their observation feedback into the realities of their nursing practice. So the workshop is quite very participatory in nature, and we use a lot of role plays, a lot of demonstrations, and we have 7 modules on this workshop that we cover. And one of the modules that we cover is on dealing with death and how to support parents in the newborn unit. And then after the workshop, we release them to go back to their work environment and put the skills they have learned into practice in a more informed way for another 3 months. And then they give us feedback of how the skills are working in their work environment. And then after that, we invite them for another 3 days workshop to finalize the learning, share our stories and successes on how the skills have made our work different and better. Next slide. So for the last 3 years, I've been working with the newborn nurse managers across 16 county hospitals in Kenya. So in 2019, I trained the nurse managers on this process training. And then on 2020-21, I trained them as trainers with the aim of scaling up the training into their hospitals. And for this year, we have run up 2 pilot trainings led by the nurse managers with my support in 2 county hospitals. And this is part of the ongoing work that I'm currently undertaking. Next slide. So these are just examples of before the training and after the training in relation to bereavement. And this is a quote here from one of the NBU nurses saying, when dealing with a mother who has lost their baby, it is quite difficult and it makes much of one's time. So it takes much of one's time. So given the workload that they are already managing and then supporting a mother to them, they felt it's quite very difficult. But after the training, this is what they are saying, allowing parents time to stay with their baby. So earlier, I could not allow them to hold the baby and allow time with the baby's body. But post-training, I can give time for the mother to grieve and try to answer her concerns as much as I could. So we are seeing a lot of difference in the way they are now doing, in the way they are helping their parents in the NBU unit, given the skills that they learned in this training. And there is more, there's a lot that I can share, but because of time, I chose just to focus on the bereavement. Next slide. So as part of my ongoing work, so currently we are undertaking in-depth evaluation approaches of the TOT program and the pilot trainings that we conducted in the 2 hospitals. And then we are also incorporating patient experiences into the communication modules and pilot them in our national hospital and in our national maternity hospital, mainly focusing on the newborn care staff. So last week we had a co-design workshop where we invited the nurse managers from the newborn care units and mothers of ex-preterms like David and Purnesh. So we had them in one sitting and the mothers shared their experiences, how they were handled in the NBU unit, what they liked, what they did not like, and where we need to improve as health workers. So it was quite a very informative session to have the parents together with the nurses. And there was a lot that we could learn from the mothers. Very good insights on how we can improve the way we care for our patients. Also, we are looking into exploring how the training can be brought into the nursing curriculum. So that's also an agenda that we have in mind, and we're working towards attaining it. So that's all I wanted to share about my experience. I hand over to Nina.
Thank you. Thank you so much. This has been a very heart-wrenching session in many ways, and what you all said is so true. And some of the observations I've been reading on the Q&A and the chat are very supportive, and people have those experiences too. Maybe I can just read out what Elizabeth has said in the Q&A. She says, excellent presentation. For privacy, we can only use our personal office within the clinical area. She cautions having a specifically designated room for bereavement counseling. I do agree. This is probably, if we have a room separated, then maybe that is something that may never occur in some of these facilities. The next question, and I'm unfortunately I can't read the script, but what I see here is so important. And Moana, I think you responded to that when you spoke just now. What I read here is, thank you for sharing this important topic. I always feel the topic, the grief, bereavement care is so important everywhere, at home and NICU. According to my working experiences in several countries, I believe important for families, especially mothers, to stay with their newborns when they die, even in the NICU. What do you think? Is it possible? And I think the presentation you heard just now has shown that it is possible, and we have to make it possible because that's so important. So I'm also now reading another from Kondwani, interested in experiences related to implementation of and access to family-centered care in private or cost recovery healthcare public health models. What are the cost implications to both families and health facilities? I'm wondering, is there, Arti, do you know, would you be able to answer this question? Sorry to put you on the spot, but anything on family-centered? Yeah, go ahead.
Yeah, thank you. And thank you everybody for being patient listeners. Yes, regarding implementation, I have a lot to, say, but I guess the only thing I would say is it's a very thankless kind of a job, which may appear to be, but it's really, really rewarding at the end. And initially you will have all struggles. It's an iterative learning process, how the implementation happens. You see day to day, you see that how you get successful at the end of it. And regarding the cost and the biggest challenge actually has been, getting the healthcare provider on board to, why should they, what do they gain out of it, to get their mindsets to change, that how important and why it is important that we build competencies of the parents and why we empower them and make them respectful partners in care. Now, regarding the cost and access in private or in public health setups, you see, there are indirect costs to the parents, because in any case, you are now engaging them, in an active manner, and they are very happy to do so. But it comes at a big cost, because they are, in our country, they are mostly poor patients. Economically, they are quite challenged. And then in that case, the parents are there, the mother is there, and the father is there to look after the mother and do all the other, running errands. So the families work, the earning gets compromised a lot. And the fathers are out of job by the time, it's 2 months or 1 month, the father has been there. He is not able to go to his work. Mother has small kids at home, whom nobody to look after. They're living with neighbors. So it's an extremely stressful, experience for them. And sometimes, money becomes so draining. Although in public health, we are trying to, minimize the cost out of pocket expenditure for them. But I know that in private, we have invariably so many patients requesting for transfers and admission to our NICU, because they know that we are providing free care. Otherwise, the cost is actually amounting to 60 60,000 rupees a day, almost, I would say it's about how many dollars you can calculate. So 60,000 rupees in a day, and you don't know the time they are there. So it's really draining for them mentally, physically, emotionally, and in every possible way. So I think we really need to get family-centered care into the practice.
Yes, thank you, Aarti. And I think it's about, the private sector. It seems like one is the public sector and the private sector is another area. And that's a really good question that was asked. How do we get it into the private sector for people to actually be able to provide family-centered care in the private facility? It's a very, very critical question. Another bridge to be crossed in the future. I note Priscilla has noted that development of guidelines and resources is very important and urgent next step to strengthen family-centered care. That's very, very true. And I'm just giving a quick scan. We have just five.
Nina, sorry to interrupt, Nina. I think I missed that part. Can I just revisit this part of, in private, what is the cost and what are the implications? Can I quickly touch that?
Maybe, Aarti, if you could just say, how can we get the private sectors to actually do family-centered care?
Yeah, so I said that, healthcare providers are biggest challenge to change their mindsets. We've had some fora at which we have had discussions and, panel discussions about family-centered care application in private. But, their mindsets are like, why do we need to do it? Because there is a commercial, at the back of it, there is a commercial interest for the hospitals, which are actually owned by businessmen. So they are not interested because getting the parents in may decrease the hospital stay, may become transparency in care becomes very challenging for them because there's a watchdog effect. They don't want things to be as transparent. Some things go wrong and then patients can sue them. There are fears of related to that. And also, getting parents into the nurseries will also has cost implications. Parents are already getting drained with their expenses. And now you have to get them gowns, you have to get them to wash hands, you need hand disinfectants and lots more things. So therefore, I think they are quite hesitant and very skeptical of starting this.
Rightfully so. I think I can see, all of us can see that connection. Thank you, Aarti. That was very, very helpful. I'm just quickly saying this is from BC. Okay, nurses in particular are mostly occupied with so much work as a result of a shortage of staff. How do we help a nurse to properly conduct bereavement disclosure to parents in the face of many challenging patients in the ward? Such a good, valuable question. Who wants to respond to this? Maureen or Moana, one of you?
I can start.
Okay,
so
thank you.
It's really not easy. As I said, these issues of bereavement care, we also have to consider that the nurse is also an emotional being. They also have emotions attached to that. And also when it's time that we've lost a neonate, there's also something going on in the nurse, like I've failed, how do I break the news? So there's no clear-cut answer, but it's just a matter of understanding the context in which one is working on. And also when the nurses are particularly trained and prepared on how to handle their emotions and how to handle the family, that could be a starting point, because if they are trained, they'll be able to understand how to deal with their emotions, then they can help others better. And also within the setting, how many nurses are on duty? Because this is also a priority. So it's just a matter of task allocation and looking at the team that is working in a duty and to check who has the skill and the competence in providing bereavement care, so that they have to be given that time to manage the family that has been bereaved. So it depends on the setting, but still all I can say is bereavement care has to be prioritized just like any care. We don't have to ignore the parents that have been bereaved because they just need our care as well. I hope I've answered that badly. I can also give it over to Mwana so that she can extend from there based on her experience.
Thank you, Maureen. I think you've said it quite so well, because this is, often nurses feel they're too busy to support mothers when they have lost a baby. But during the training, they raise these issues, and we try as much as possible to put the nurses on the shoes of the parents, that if it were you in this situation, how would you like to be supported? So that the skill of empathy is one skill that we really emphasize in the training, the ability of you as a provider to put yourself into the shoes of the parents and see how would you like to be supported. So we use a lot of role plays where we put the nurses to play the role of a mother and imagine how it is when you are in that situation as a carer. So often they say we are too busy, but once they have these skills, they are able to set aside time and work together as a team. Because if you are, for example, you are 3 of you on duty and there is a mother who has lost her baby, then teamwork comes handy, that we let you handle the mother as we continue with the other tasks. So it's all about teamwork and the ability to empathize with our patients and put ourselves into the shoes of these mothers and see how would I like to be handled if it were me in this situation. And I think the co-design workshop we had with the parents last week, it was quite very insightful when the mothers shared about their experiences of losing their babies in the NB, in the newborn unit, and the kind of support that they were looking forward, which they did not get it. So it was very, very emotional. And we got some of the health workers shedding tears from hearing the stories the mothers had to share. And that was an eye-opener to all of us. And I could see already from that workshop, the nurses saying what is it that they can do or they can change to care for the patients better. Okay, thanks. Thank you, Nina. That's all.
Yes, thank you both. That was very, very helpful. I was just quickly checking the chat, and Prince agrees that understaffing is an issue, but as Maureen and Moana said, that's not an excuse. This is so important to focus on. So we have to change our mindset. And Edmund notes in the chat that I think not only the nurse should be responsible for bereavement care, doctors must also be actively involved. So true. It's not just, it's the whole team, as Moana noted. And Project Eco Nest. Now, there's a person behind it, I'm sure. Do hospitals have community groups that assist in bereavement care? Do you know of such community groups in Malawi or in Kenya or even India?
No, from our hospital setup, we don't have such kind of an arrangement, but I think it's high time we also need to look into those kind of interventions to see how we can support our parents better. But often it's just the nurses, the clinical team, and the parents and the grandmothers who are supporting the mothers in the units that come handy to support a mother who has lost a baby.
I think what Maureen, yes, absolutely presented, the social network in some of our countries, that's the backup. They should not be stigmatized. And if this comes out as open and the suffering that parents feel and is supported, that's the biggest thing. I think we could go on forever. This is a topic so important for everyone to listen and talk about. But I think time is not on our side now. So I'll hand over to Professor Bharti to close our session. Thank you so much, all.
Over to you. Thank you, Nina. It was indeed a very, very interesting session. And well, I would just close by saying that, yeah, we learned today a lot. The fact that implementation toolkit and the modules for bereavement are open access, very useful resources and hubs for small and sick newborn care. And it was very important and good to hear that, we are bringing home the point as how important this bereavement care and supporting the families, and also about emotional competency building and, getting it to pre-service, how important it is, and to strengthen the care and, improve the quality of care. Regarding family-centered care, which is actually my baby in the country, well, the journey started off as I would not hesitate to say it was a discovery by accident. Why? Because we were struggling with severe HR constraint. And therefore, we started using parents. Using is the word. That means passive participation, to improve the quality of care, to involve them in mundane tasks, and, spare the nurses of more left to do more technical and skilled tasks. and how this using them, showed us the fringe benefits to all the stakeholders with a win-win situation for all, including the parents, babies getting better care, parents being by the side of the baby, and they're getting to have competencies built, and the nurses and doctors with work sharing. And seeing this passive transformation, passive participation, how it shifted on its own to transformative participation was amazing. It actually led to development of respectful partnerships between healthcare providers and receivers of care. It has brought a paradigm shift in small and sick newborn care, and it has actually built competencies among the parents that actually are so lasting in impact, because they form a linkage of care and a continuum of care to bridge the gap between the facility and the community newborn care to improve the neonatal outcomes. And I have not only seen that this is a short-term experience, it actually we have documented shifting equations between healthcare parents and parents, of course, between fathers and babies. We never saw fathers being so much involved, and there are, I think, opportunities for lifetime bonding which develop and which are happening. The mothers we have always seen, but fathers engaging in care, you just heard Karunesh, you heard Daniel, they are just tip of the iceberg, so to say. But we are seeing this day in, day out, which is very unique and very heartening. And women get, more empowerment. The woman's status in the family has risen. The women are now considered as somebody who makes a difference and whose decisions matter. And then I think this overall, I think then our program, we have learned a lot for implementation. We have published the implementation bit. And as I said earlier, the implementation, the biggest challenge was not the mother, not the parent, not the baby, or not the logistics, not the other things. It's all about mindset, changing the attitudinal or mindset of the healthcare provider. If we can do that, that doesn't happen overnight. It has happened over years and years. And it is persistent, non-tiring effort, which you have to have champions. You have to have leaders who can actually persistently, perseverantly, and passionately follow this, that it must not be given up. It has huge, huge, huge benefits. And we have had parents who have lost their kids, but they went, actually hugging me and saying that, it is our bad luck, you've tried your best. So it's not like the blaming and the other things that you often hear. Those things have gone. And now it is, fortunately, our country has been great that, it took leadership to the political level. And now the National Health Program of Family Participatory Care has been launched in 2017. It has been scaled up to work at various district levels at all 800 districts. However, I must say, implementation is a different ballgame. We may say family participatory care is implemented, but how it is implemented, that really needs to be monitored, evaluated, and quality of care is important. It's not just passively involving mothers and parents into care. It's much, much more than that. It is actually a respectful partnership of care between parents and healthcare providers. I think I could go on and on, but I think I'd stop here. Seeing the watch, I've overpassed by 3 minutes. And I really think family-centered care is the way forward. Thank you all so much for allowing me to speak here. Thank you so much.
Thank you all. Have a good day, evening. Bye-bye.